like some of them are out smoking and the rest are surviving the whole issue here. Let's see how we get going on this thing. Want to give me a hand with the technology?
Sure. Right arrow.
Got it. Okay.
Moves you forward.
This is one of my favorite clinical photographs. This was taken by my associate, Dr. Gareth Gilkey, a survivor from Nam prison camps, and a totally bright guy. And this shows you the whole issue. You have clubbed fingers and a cigarette and nicotine stained on the index finger. That tells you the whole issue. Adenocarcinoma of the lung related to cigarette smoking. That's just one of the consequences we look at. What's the incidence? The incidence used to be 24% in adults greater than 18. These slides are from 2006. The initiative the federal government tried was to get a value below 20%. And actually now the total number of people smoking since 2006 has declined to 18% of people over 18 in the United States. That is huge in the reduction of risk reduction for chronic health. Health consequences, oh my heavens, it's amazing. Now, the prevalence actually is variable depending on the states. The highest number of smokers is in Kentucky. The lowest number is in Utah. And California actually has a very low number here. I think you can see that, that men smoke more than women, and that the declination of cigarette smoking, when I was a kid in the 50s, I would say that over half the adults of over age 18 smoked cigarettes. Now that's simply not the case. We've had a dramatic reduction in it. And I'd like to tell you that it's all about education, and that has something to do with it. But most recently, it's about cost. It's about cost. The people just cannot afford, and in New York City it's $10 a pack, I think, for cigarettes now. So cost has a huge impact on the kids getting into the smokes, and of all the education that we tell these guys, the cost has a greater factor, in my opinion, than those who are able to quit. And this is the geographics we were talking about here, where you look at the cigarette states, the retirement states, and then over here, California is way low, and actually Utah is even lower than that. So we're making huge progress because of the fact that, that it's very socially unacceptable. I saw a cartoon that shows the guys in California, and they're all out rolling the joint smoking, and the guy opens a pack of Marlboros, and they all have this death-defying look. What the heck are you doing? You know, they don't mind the marijuana, but the nicotine was totally unacceptable. I kind of like that. So 7 out of 10 want to quit. 8 out of 10 have tried it. A third of them give it a real shot each year, and most people require 10 or more attempts. We were totally wrong in the addictability of cigarette smoking. I was totally wrong. I ran a drug house for kids in college because we had a huge number of overdoses when I was up in Indiana. And I heard this story every time. Not one person told me a different story. The heroin was tough. Alcohol and cocaine, those were tough. But these damn cigarettes, everybody told me the same thing, and it sort of went right in and out of my ears. I should have listened more carefully. And so it's a real hook, much more of a hook than we ever realized, and that's why it's harder to quit. I personally do not believe that education is the answer at this point. I think it's the reduction of withdrawal symptoms that's going to be the key in the future. People would like to quit, but they feel so lousy and have so many consequences of trying to quit smoking, nobody wants to put up with them, okay? And so the future, in my opinion, is reduction of the consequences of withdrawal and not further education. And so for pharmacology people out there, we need to look for a drug that will help block the consequences. And so we know that there's carcinogens. You can see the heavy metals there on one side. The lower yield of tar and nicotine. What do you know about that? the low-tar nicotine cigarette. You know what? The tobacco's no different. All we did was punch holes in the cigarette near the base or the filter to put more air in there. And so the guys who smoke would simply put their finger around the cigarette and so get to the same amount of tar and nicotine. There is no such thing as low-tar nicotine tobacco. It doesn't happen, okay? And so, why on earth would the manufacturers of cigarettes want to make a higher concentration of nicotine than you'd smoke less cigarettes? Because people do not smoke for the flavor or all that stuff. They smoke because they get nicotine out of there, and that's why, that's the hook in this circumstance. So nicotine is the substance in all cigarettes that causes the addiction, first, second, and third. We know the consequences now, and even in reproductive, ED and reduced fertility and low birth weight and sudden infant death are actually real things that that in my generation 50 years ago when I got educated, we didn't really know of all these consequences. All these things have a definite statistical correlation between the health issues and the cigarette consumption. So we know that all these causes of preventable death, that one of the things, if we could get people to take their pills for hypertension, as Dr. Basel points out, and do a packectomy, we would certainly help the health of the nation greater than anything else we do. And the diseases in terms of mortality, this is an old hat. We know that the lungs and the heart and neoplasms occur for most of the issues of death and dying. And the question is, well, when do we quit? We used to tell guys who were 60 years old and still smoking, it probably doesn't make any difference. Actually, this timeline shows that no matter when you quit smoking, you're going to gain longevity. And the statistics show that even if you smoke, if you can quit by age 40, you are going to get back to a much more normal death risk than you would have if you continue to smoke. But the cutoff seems to be about 40, which is a lot of years. That's roughly half the life expectancy. And yet if we can get people at age 40 to quit, then they may go back to a more normal death risk than we had previously thought. So quitting is a big deal. And this shows, this is some data taken, I think this is from the British Health, doctors smoked there. And what they showed was that if you looked at when they quit, they liked the guys to quit at the age of before 40. It had the greatest benefit in terms of health improvement and death risk reduction. And this shows again that at every stage and every age, it's always worthwhile to quit. So throw them away if you can. Obviously, when we look at secondhand smoke, I'd like to point out that sometimes things don't get published because they're politically incorrect. And that burns me. I'm actually a scientist. That's why I asked Jan all these tough questions about little fragments that may make a difference in outcomes. I think we're all scientists at heart, and we'd like to have somebody tell us the truth. There was a study done by the World Health Organization in 1998 that was a negative study on cancer. Negative. They refused to publish it. Finally, the British Medical Journal got a hold of it 5 years later and published it. And they got a lot of nasty comments about it. But cancer itself is probably not a big event for secondhand smoke. Now, that doesn't mean that there aren't other consequences. But to be intellectually honest, don't say that cancer is going to happen. That's not it. And this was an estimate of all these excess deaths. I think that's probably not correct. Heart and lungs are the major impact. And then the asthmatic people in the family and other siblings in the family have a big negative impact. When you wheeze and cough and you're in a smoke-filled environment, it is definitely a bad episode and a triggering event for the guys that aren't smoking. So we're going to look here and look at the addictive nature of nicotine. and then the role of the alpha-4 beta-2 nicotine receptor in tobacco dependency, that's the hook, and then the nicotine effects on the dopaminergic system essentially, and then the cycle of nicotine addiction. So let's take a look. We think that there's a very blast effect when this stuff hits the brain. The lung is a doubles tennis court for absorbability. And so when you inhale this stuff, it really rings your bell quickly. And as anybody who's ever smoked as a kid, and I'm sure we all did, you smoke that first cigarette, and after you get done throwing up, your friends laugh at you and say, you should have tried it a little more gradually. Well, the truth is that that brain blast it hits the brain within 10 seconds and lasts a couple hours, and then people are looking for more of a nicotine. And so it says it's similar as it's a chronic relapsing condition between the known drugs that everybody is more worried about. And then obviously the nicotine and these drugs act on different areas of the dopaminergic system, and that among the users of alcohol, all this stuff going in there, we see multiple addictions. Tobacco users are more difficult to get off the smokes than the others. And that's sort of new information. We certainly didn't know that when I was in medical school. And for the record, that was 20 years before Jan was in medical school. It was even worse in my era. So we think that this blast occurs, and here's what happens. You get to the nucleus accumbens. Whoops, sorry here. Let's go back. You get to the nucleus accumbens after the VTA area in the midbrain is activated. This nucleus accumbens then gives you the dopaminergic blast, and you get a reward. So the obvious physiology of why we need to know this is if we can interfere with that reward or stimulate the receptor to think that it's getting that reward, that's what the pharmacology guys were looking at down the road here. And so we know that smokers can actually self-regulate nicotine puff by puff. There's about 1 to 2 milligrams, that's milligrams, of nicotine per smoke. 100 millimeters is going to have a little more. The filters do not filter out the nicotine, they filter out tar. Obviously people wouldn't smoke if they didn't get the nicotine. And in order to get a steady level, patients are able to titrate and avoid the symptoms of withdrawal and craving. And craving is about as important a thing as withdrawal. So the cycle is that when you try to get off, these things occur, and they all occur rapidly. And so the tolerance and physical dependence and craving have got to be blocked in order for us to go further in reducing the amount of smokers in the United States. So what do we have available? We've got nicotine replacement therapy. I'm going to talk about e-cigarettes a bit later on. We've got Bupropion, which is an antidepressant, and this was the first drug ever shown to be effective. I worked in the psych ward, seeing people on the psych ward. If you've got a sick medicine person in the psych ward, it is a nightmare. The psych ward nurses don't seem to have any knowledge of medicine in their brains. It's all about the psych issues. And when you got a crazy there with a lot of consequences, it is a nightmare. And the medicine nurses don't want the psych patients there. So that's when they sent guys like me who were durable enough to go in there and watch. And one of the things that me and the psychiatrist noted is that when they used bupropion for depression, there was a smoking center. It was like a basketball court out in the middle of this crazy ward, and everybody would go out there and smoke. And the psychiatrist and I both sort of gradually noticed that the guys on bupropion were sitting watching TV, and they didn't take the break outside. And we were, about that time, realizing that this drug was doing something so that the guy, and usually everybody in the psych ward smokes. It's just the way it is. Well, these guys were not smoking, and they said, it doesn't give me the same effect anymore. About this time, there was published literature to show that indeed our anecdotal observation was correct, that there was a difference in the response to bupropion in the fact that they did not want to go out and smoke. And that was the first real breakthrough drug we had. And then nicotine replacement therapy, we had patches, we had gum, we have all sorts of things. We even had a nicotine inhaler which never got off the ground, but probably we should have looked at that a lot more carefully. And then you got the sustained release of bupropion, which received a FDA approval fairly quickly because they're happy to find a drug that works for anybody that wants to quit smoking. So now the NRTs, or nicotine replacement, these were a variety of inhalers. The absolute worst was the nasal spray. A guy brought me a sample and said, try this, and it burned all the way down. It's why anybody would use a nasal. It was terrible, and it did not get great accolades, but it was actually, it gave higher nicotine levels and was more effective than any other of the nicotine replacement therapies that were tried on head-to-head trials. And so in 1997, way back, bupropion got an indication to aid it, and then we kept looking for something that might be a better receptor site blocker. And so the smoking trials are very difficult to interpret. Most of the stuff that the gums and the nicotine replacement were 12-week trials. That's a joke. 12 weeks is nothing for an addiction as big a hook as smoking is. And so later on, the FDA realized there was an error in their judgment, and they wanted then 3 months, 6 month, and a year trial to show, hey, down the line, is this stuff still working? And so this led to a little, and then the other question is somebody checking carbon monoxide levels, or you can actually measure nicotine in the serum? Is anybody actually looking to verify? The patient said one thing, what does the body say? Because the body's always the guy that's smarter than any of us when it comes to outcomes. And so continuous abstinence means not one puff of one cigarette. That's a pretty tough trial, and it's a pretty high standard to meet for any sort of drug that's supposed to be effective. And so, and this thing just shows the pharmacotherapies and the effectiveness at 6 months. And again, that's again when they started looking at is the hook out of the body for a longer period of time. And this really shows that a number of studies and actually how effective they were. And it turns out, and a short statement is, the higher the nicotine level that the drugs put in the body, the better the outcomes. Why? You're relieving the symptoms of withdrawal. That's the whole issue here now, not just education. And yet when you look at bupropion, boy, you know, it's a 17.3% at 6 months, and nicotine gum versus placebo for some reason was quite high at that time. That has not been my experience with the gum. It wasn't near as good as they were supposed to have it be. So anyway, and what this really shows is here, this is the how much bang do you get for your buck. Here's the cigarettes, that's 1 to 2 milligrams, and obviously that was the biggest bang. And then the gum, and that was the 4 milligram chewed rapidly, and to no surprise, that was the second best because it had the highest level of nicotine replacement next to smoking. And then the transnasal spray, and I can tell you nobody's going to be compliant with that. And the patches were a relatively not so good because they didn't give the nicotine levels that the patient demands because of withdrawal symptoms. So nicotine replacement products, contraindications, they didn't like to use them after an MI. And if the kids pick up the patches and chew them or stick them on their body like grandpa, they get pretty sick from the nicotine. And then obviously the adverse effects are going to be the patch with skin irritation, and nicotine causes a lot of other side effects as well. And most people have a puristic bad attitude about getting an addicted person the same drug they're addicted to in order to try to accomplish what our goals are. It just doesn't quite ring to us. And so anyway, bupropion, the biggest thing is you got to watch for, they got a bad liver and for seizures. And we don't push these drugs at all to their maximum. Bupropion especially will cause seizures in people that never had it in some individuals when you start using doses above 300 milligrams. And so they're looking at all this, the problems here, trying to look at how can we reduce the consequences. And so the patches didn't work all that well because they were, you can see here, and right now they're even hard to find. You can buy these over the counter, by the way. The FDA decided to anything to help these people. And so you notice that there was a great amount of confusion in how they should be used. Docs who were trying to help people were driving themselves crazy with which patch is what, and that was part of it. The nicotine nasal spray actually was pretty good, but it was so horrible nobody would use it. And so this is how you're supposed to use it. And I can tell you what, when I used it once, I would never use it again, and I wasn't a smoker. It's awful. So anyway, so this is what they said. Nicotine inhalers, they work pretty well, but nobody pushed them. They just didn't push the nicotine inhalers, and so that was a real consequence. Bupropion, basically, we'd like to use 150 milligrams twice a day. That was the FDA dose, but we do not go higher than that. Above that, if you get up to 300 milligrams twice a day, you may see seizure activity. The side effects, obviously, is some of the elderly people felt a little sedated and knocked out with this stuff, and obviously, you had to titrate it in older individuals. And again, why are we giving it in older individuals? Because the British Health Study shows it makes a difference in outcomes. And so that's what we're looking for. Varenicline basically is the drug Chantix, which came out in 2006. And as a matter of fact, at this seminar in 2006, the first lecture in the United States was given on varenicline. Why? Because I got the slides 2 hours before my lecture, and we were able to show the varenicline. Varenicline basically is a drug that blocks the alpha-4 beta-2 nucleus. And when that occurs, the symptom of craving goes away. Now, one of the things you have to watch for varenicline is that if you've got any person with major depression, do not, N-O-T, not, use varenicline. Remember, it comes in in the low dose for a week, and then the usual dose following that in terms of packages. The company, Pfizer, never gave out any samples, and it has to be used for at least 3 months. This is more of an addiction than we ever thought. If a person gets nausea and vomiting, which is the usual side effect to be expected, at least nausea, you can bet they're still smoking. One of the things it does is it changes the way cigarettes taste. And when I went to the big seminar in Atlanta and then in my own experience, people would start on the low dose varenicline, and they would call me and say, gee, can I just quit smoking right now? I don't want to smoke anymore. And they don't taste like they should. They actually were wanting to just go right ahead to the higher dose because they didn't want to smoke anymore. So it was very effective in terms of reducing the symptoms of withdrawal, and they felt satiety even though they got the sensation, since this is parked on that alpha-4 beta-2 nucleus. It's called it's a partial nuclear blocker, the alpha-4 beta-2 nucleus. People are satisfied that they don't withdraw, which was in that pathway that we showed earlier. That was the whole purpose of looking at the pharmacology of it. Can we interrupt the withdrawal symptoms by giving something on that nucleus that says, I got what I want. And that was the whole thing about varenicline. Now, bupropion probably acts the same way. If you look at 1 year's abstinence, about 21% of the people on varenicline and about half that number on bupropion will remain smoke-free, not one puff of one cigarette. So that there's about a 50% improvement in varenicline. However, it costs a lot of money. The average, well, nowadays, it started off at $110 a month for 3 months. So that's only $360. Now that cigarettes have gone up in price, it becomes obviously comparatively more affordable. But that was one of the things that people didn't like, was it cost $100, and they always say, I can't afford it, but they're smoking 2 packs a day. Excuse me? Let me get this right now. You can afford the cigarettes, but you can't afford to quit the cigarettes. This is a 3-month trial. Cigarette smoking is the rest of your life, however short that may be. Okay? And so don't buy into that argument. It's too expensive. Now, this is an interesting drug that the New England Journal had about, and this was in December of this year. I had never heard of this drug, but apparently in the Eastern Bloc nations, it was a well-known drug. And this is a drug called Cessation. And so this thing was published in the New England Journal out of New Zealand. And by the way, New Zealand they don't market this drug as a standard remedy. But what they did was, these people only took this drug, and they have a tapering up regimen of how it's supposed to be used. They only took it for less than a month. The cost was $30. That's the high cost for this drug. It could be purchased on the internet under a couple different names, apparently, and this was all self-reporting. And then that's always shaky at the very best. But it's probably a drug that works like varenicline and like the drug bupropion. And I say probably because this hasn't been studied scientifically. There are 2 manufacturers in Europe that make this drug. But anyway, a drug that costs between $25 and $30 totally, a treatment time of less than a month, and these were the numbers that were quoted here. 40% had quit with cysteine, and 31% had quit with nicotine replacement. At 6 months, it was 30-30, and they'd remained abstinent. And this nicotine replacement has to be the gum, because no other form gives you that much nicotine. So, and anyway, now, in the 1980s, it was called a favor inhaler, and it evolved into the Nicotrol inhaler. And it never really caught on. Nobody pushed this. I don't know why, but again, we don't like people puffing on anything. It's sort of our Judeo-Christian heritage, where we just think a little differently. We ought to say whatever it takes to get people off the smokes, that's our goal. It's not our biases or our opinions, it's whatever works. And the body's always smarter than Pell, guaranteed. Now, when I looked at the whole thing of e-cigarettes, there is a paucity of any sort of data to show how good it's going to be. And why should these companies go to the bother? What we know is that in 2013, the use of e-cigarettes, are you ready for this? $1.7 billion market in the United States. $1.7 billion. And what the problem with them is that even puff by puff, the devices, which has a little warming device and then an aerosol chamber for a liquid which has varying amounts of nicotine in it, even puff to puff, you don't get the same amount of nicotine. And when you puff more frequently, it doesn't necessarily give you the bang for your buck that you're anticipating. The FDA was bound and determined to regulate it, and they went to the 5th District Court in Washington, D.C., claiming that this was a drug dispensing device which basically it is, but the court did not find in favor of the FDA, and they are still PO'd about it. You know, they're going to different district courts trying to retry their case because they want to regulate it, and they probably have a point. The way this thing works is you get variable amounts of the solution, and then you got a mouthpiece and a heating element and a battery, and the cartridge can contain 10 or 20 milligrams of nicotine. So you got to keep it out of the hands of kids. 10 milligrams of nicotine can kill a child. So you really got to make sure that the grandpa does not lay this on the table so that grandchild can come along and decide to sample it and end up being dead. I don't know of any antidote for nicotine poisoning. If anybody, you PharmDs in there may help me a little bit, but I think once you got it in you, it's a problem here. Okay, and so anyway, the replacement products have up to 1 gram of nicotine in some of these solutions, and a kid can die at 10 milligrams, and yet the federal court has ruled that the FDA cannot regulate it. I can tell you this, that there is a study done, and this came out of Lancet, and what this was a randomized controlled study to evaluate e-cigarettes, and they let them puff as much as they wanted. One of the problems that drug companies have is you have to, by the standards of the FDA, have a certain dose, and then you look for a certain benefit, and you look for the side effects associated with that dose and that benefit. Well, with e-cigarettes, because the availability is so variable, they let these guys puff as much as they wanted. That I liked, because that's honesty. That's what a person who's addicted would try to do to get the withdrawal to decline. And so anyway, in this study, they looked at the e-cigarettes and they picked the 21 milligram patches to evaluate it. I would have probably used the gum, knowing what we know about nicotine delivery, but this is the way it was done. And so carbon monoxide was measured at 1, 3, and 6 months, and some of the device they used, they had to use 200 puffs. You puff them like a locomotive to get the dose, showing that in this study they did use a controlled inhaler, and I didn't mention brand names because they're not wanting to be, they get sued for discrimination from all the people selling the puffers. That's what happens. So I don't know what they use, but to get 2 milligrams of nicotine, which is what you would get out of a finished cigarette, they had to use 200 puffs of this inhaler, but at least they got the nicotine, which is the main issue. But look at the quit rates here. At 6 months, 7.3, 5.8, and 4.1, depending, showed the quit. And so what it really showed was that it's not a great way of reducing the addiction. So the cost comparisons are probably old on this slide. What about support? The companies that have sold these different products have had hotlines. So Florida's got a hotline you can call for advice on quitting smoking. Many of the people recruited for the studies were those that called the hotline. So the main benefit of a hotline is somebody will hold your hand up there and talk to you about, okay, come on, George, you know, do your best here because you really want to quit, and you got troubles and it's making you worse. But the real benefit was it's a great intake to get those people who need to quit smoking to come in to the crowd of us non-smokers and make something out of it. And so I think that was the whole purpose here. But hypnosis will help in some circumstances. It's sort of lost favor because it's expensive, it takes time, and not many people do it, but it does work. And the drug miracle fruit. Any of y'all know what a miracle fruit is? If you chew miracle fruit, it will make salt taste sweet. Miracle fruit is called miracle fruit because it alters your taste your taste brain receptors to the point where salty stuff tastes sweet. Everything tastes sweet, as a matter of fact. I've used it in people who've had radiation to the head and neck, trying to bring back their taste, because when they don't taste anything, they lose weight because everything tastes salty. It's what most people will tell you. It's unpleasant, and it doesn't work. I tried that. But miracle fruit will make the smokes taste different. And so I would look at the New England Journal on this. I can tell you that the story is not written for nicotine inhalers. Why do we want the inhalers? Because all the carcinogens, and by the way, the solutions that these things are dissolved in have had some problems, and some of them have had very small amounts of the heavy metals that we showed on that third slide, so that that has to be looked at. I think for once, and I'm not a government man, because most of the time, the three reasons we change behavior: quality control, cost containment, or expediency. The government meets none of them. You can never expedite anything with the government. The cost is always exponentially worse, and we're seeing that in the healthcare legislation, unfortunately. No surprise to us who've been around for a while. And then, how good is it in the final ballpark? And so I would really think that somebody needs to take quality at its best. If I were selling e-cigarettes, I would make sure I had a device that would put the nicotine in the system, 1 to 2 milligrams per segment of puffing, whatever it is, so that we would at least know that's what they were there for, and get rid of the tar and the carcinogens and all the other inflammatory radicals that set this inflammatory cascade that we've been hearing about from Ronnie and Jan and the other speakers, to stop this cascade from occurring. Because if we can simply replace the nicotine with a reasonably cheap inhaler, and by the way, the cost varies all over the place, but I think the government probably should get involved in at least standardizing a device that works so that you'll know what you're getting, and simply then deliver the nicotine. And right now, we don't think that nicotine does a heck of a lot to all the consequences we've been hearing about here today. And so my thought would be, let's deliver the nicotine as a less expensive way than smoking, get rid of the tar and all the other also-rans, the 60 other compounds that we know exist in tobacco, and try to make the best of it. I can tell you one thing, that if you want to know how desperate people are to quit smoking, the collective is spending $1.8 billion of their money trying to get rid of a habit that was a much bigger hook than we ever thought. Much bigger hook. So what do I recommend for my people? And because I am from St. Petersburg, which is the world's largest ambulatory nursing home, not anymore. It's actually, there's some people that actually are young in the town now. But the old guys have a lot of side effects on bupropion. It's not without its sedative things, etc. And seizures, of course, always a worry. I would probably try the low-dose varenicline, followed by the high-dose varenicline, and then any sort of, and by the way, when you use varenicline with any sort of nicotine replacement, it's a disaster. They just get sick and throw up. And it's probably going to be the same thing with any drug that affects the alpha-4 beta-2 nucleus. You really cannot combine these drugs. That was tried, and I think it was Pfizer that started out, and I think the trial lasted about 2 months before the waste baskets were full of you-know-what, and all the people in the study goes, no, we're not doing this. So a word to the wise, however, is if they're complaining of excess nausea on varenicline, then you want to really question them about, yeah, well, I had a cigarette or two along there, and believe me, they will be punished for it. They will punish themselves because it does not mix well. So what do I think the future is? I think the alpha-4 beta-2 blockers are here to stay, varenicline, bupropion, and the cystosine, which I had never heard anything about. And if I were a drug company, I would sure find out about it. What I could find about it, they did not mention any preclusion to depression. But I'll bet that's going to come up. Why? Because it's going to come up. It happens in the other two compounds. I would certainly then get some sort of a nicotine aerosol, maybe go back and review the old Nicotrol inhaler to try to see why we don't get that rejuvenated and back into the advertising spectrum so that it would actually be an effective delivery of nicotine. And then keep reminding our patients that if you're wanting to have the benefit of the nicotine, whatever that is, and you saw the things there, more alert and mentally sharper, and the digestive system works better and the constipation gets better, then I would say to the patients, there are options where you can get the nicotine you're looking for and not have to suffer the withdrawal. Okay, and that's where I would say the future might. We either block the consequences or we reduce the consequences by blocking the receptor site and giving you the satisfaction, or giving you the nicotine without the poisons, toxins, and heavy metals that go along with it. That's what I think we should do. And to he or she who comes up with an inhaler that will do that is a huge chunk of the $1.7 billion pie, in case your retirement funds are looking a little lax these days. That's what I think, okay? And I've tried stuff for 50 years taking care of people, and I'll tell you what, people really do want to quit. You know who's helped us the most? The cost and the cosmetologist, because we all know that we live in a vain society, and ladies don't want to look wrinkly, guys don't want to look wrinkly, but I'll tell you what, they have done more to help get my patients off the smokes than I was able to prior to some better pharmacologic understanding about what was going on. So the cosmetologist will say, yeah, my beautician, and I had a buddy in 1970 who told me he would never do a facelift on a smoker. Plastic surgeons, many of them will not do facelifts on smokers. You know why? They don't do as well. They don't do nearly as well. How about that? Short and sweet, huh?
Thank you.
A question?
There's been some controversy about dissolved lipids with the e-cigarettes and pneumonitis. Do you know anything about that?
Dissolved lipids? I didn't find so much about the lipids, but they had all sorts of other nasty products, and they list them in their immense numbers. But they're in very small amounts, and in reality, every new therapy has a critic that's sure it's going to be the damnation of mankind. Well, one thing for sure is, when you're playing a poker game with smoking, you're going to lose. One way or another, you're going to lose. I would much rather play the poker game in which the stakes were much better controlled, so I get the puff happiness without the consequences of death, dying, and destruction that we're hearing about here with all these terrible things that happen with hearts and other things. So thank you very much, and I'll see you guys in for a couple more lectures later on down. I got some more fun stuff. Thanks, Dr. Piesiak, Miss Ronnie, for having me here.